Good afternoon, friends. My pleasure to introduce Dr. Ajay Mahajan. I had the pleasure to escort him as well as a very humble and modest man. He doesn't know that I know him quite well about all the services he is providing at the KEM Hospital. A man with passion, compassion, a man with a golden heart. He has been associated with SCL, which is a very special executive job with the DCGI and FDA of India. He has been in this industry has been a cardiologist for 30 years and been head of the professor and head of the department of GS Medical College and KEM Hospital. He has been writing several letters, writing a lot of details of scientific programs which he has been conducting locally, Indian and internationally. He has been in this industry along with his other friend Dr. Sabnis, which he is going to assist him also today. And whatever doctor has been doing, I mean, to be honest, if you go there and personally look at what he is doing at KEM Hospital, he has been treated like a god over there. I would like to present you Dr. Ajay Mahajan. He will be speaking on this.
Respected members of Rotary Club of South Mumbai, it is Seaface Club. This is very esteemed gathering of all people who are really impressing us and helping all our poor patients in dire need. Though we are there as a faculty position at a great hospital like a KEM Hospital, which is funded by BMC, but always sometimes it is very difficult for us to carry out certain procedures without the help from other sources. And at that moment, you are the best people. You are the best people who can support us, and this is one of the best humanitarian gesture for improving the patient's quality and quantity of life. So everything started in the KEM Hospital because it is one of the most ancient hospital. Now it is celebrating 90 years of its presence, and it is one of the most pioneer hospital because it had done many first in cardiology, like the first cardiac catheterization in India in 1960s, first balloon arterial septostomy in India. So balloon arterial septostomy is a procedure which is done in patient, small childs who are less than 1 month of old with the transplantation of blood vessels, and first balloon dilation of aortic arterium in the world. Then we had done a first transcatheter closure of ASD in Western India. Then we had done a first dextrocardia commissurotomy in the world. That is the only patient. So there are multiple things which are done in the KEM as a first, and it is one of the most pioneer department. And now we are doing all advanced procedure. So if you name the procedure in interventional cardiology, and at KEM we are doing those procedures. Recently we are doing transcatheter wall implant procedures. Because I am DCGI committee member, we get some free walls. So we get a US FDA approved walls which outside cost is 18 lakh rupees. We are getting it free of cost for the patient. So we are doing those cases. So these are the certain patients which are supported by you people, and they are giving the important improvement in the life, quantity of and quality of life in this particular patient's life. So this patient born with this particular condition which is known as coagulation of aorta, and because of that his blood pressure in the upper body was very high and blood pressure in lower body was very low, and because of this high blood pressure in upper body, his heart is having involvement in the form of decrease in the heart function, which is ultimately leading to the heart failure. So in this scenario we have to do the angioplasty of this particular scenario, and we have to stent that particular posture with the stent. So this is a coax angioplasty with the stenting, and it is also supported by Rotary Club of the Mumbai. Then this is the procedure. This is some virtues who born with defects in the hole in the heart, which is known as ventricular septal defect. Ventricular septal defect is one of the most common congenital anomaly. Out of all congenital anomalies, around 30% patients are born with the ventricular septal defect. So most of these ventricular septal defect, they are classified depending upon their size. If they are smaller one, medium and large size. So large size ventricular septal defect, we have to treat them immediately after birth. Most of the time the treatment is surgery only. But moderate size ventricular septal defect, we have to palliate those patients with the drugs, and subsequently if they don't close spontaneously by the age of 4-5 years, and if they are having persistent symptoms, then we can close that defect with this particular type of device, which is known as a duct ventricular septal occluder, and this is that particular procedure. We can close that device. So that device is closing the septal defect, and now it's closed. So these are the procedures which are done interventionally. Then this is another important procedure which is known as balloon pulmonary valvuloplasty, and this is one of the most rewarding procedure, because sometimes if the pulmonary wall is stenosed, then right side of the heart is under pressure, and because of that one get symptoms of right heart failure, or symptom of decrease in the cardiac output from right side, and symptoms of syncope, giddiness and all those things, and that can be very well taken with this balloon valvuloplasty. And after balloon valvuloplasty, patient improves on table and goes home without any symptoms. So this is very interesting patient. This patient got two congenital anomalies. One was a major anomaly which presented at its neonatal age group, that is a VLT, and that VLT was closed when she was very small. And subsequently there was another anomaly which was remaining, that is a patent ductus arteriosus. So that was closed with your hand and support just on 31st May 2022. So we can close multiple defects if the indication is there without surgery, and patient can get significant symptomatic improvement. This is also balloon pulmonary valvuloplasty. So another important procedure we started in KEM is retrieval of certain pacemaker leads. Most of the time the pacemakers are it is the biggest invention of 20th century is the permanent pacemaker, because permanent pacemaker is the only thing which gives significant survival benefit. If somebody is having complete heart block and if you give pacemaker, it 100% is going to improve the survival of that particular patient. So most of the patients with congenital complete heart block, when they are very child, very smaller, that time they don't take a dual chamber pacemaker, they go with single chamber pacemaker, and subsequently when they become adult, we can do the revision procedure and take out that particular pacemaker and put another pacemaker. But most of the time to take out the leads which are already there is slightly difficult, but the lead retrieval is also started at KEM, and we are doing that particular surgery in KEM. Then this is the most rewarding procedure. This is a complex anomaly which gets presented with a sudden heart, chest pain and heart failure, and that is known as the rupture sinus of Valsalva. For that rupture sinus of Valsalva, previously the surgery was the only option of the treatment, and the surgical treatment was very cumbersome, and the mortality in the surgery was around 10 to 12%, and it was very difficult surgery. So if the KEM Hospital, particularly my teacher Dr. Praful Kirkar sir, he had developed that particular intervention. He is the pioneer of that particular intervention in the world, that is the device closure of the rupture sinus of Valsalva. He is having biggest series and he standardized the procedure. So here we are closing that rupture sinus of Valsalva with this particular device. So both the heart coronaries are coming differently. We are it is a very meticulous thing, and everything is not a single man's thing. It is a teamwork, and the most important person in the team is support and planning of the procedure. And for planning the procedure, we need some person who is very meticulous, very thorough in the subject, who can, because we are seeing this is a two-dimensional structure. Everything is two-dimensional, but while we have to do the procedure, that is a three-dimension. That diagram will explain you from where we have to do. It is anterior or posterior or lateral or medial. So all these things. So we have to plan it everything. So that particular thing is Dr. Girish Sabnis. He is one of the biggest planner and executor of these all interventions. So particularly the one thing which I always remember, that is a Padosan song. So most of the time I am just I am in the role of Sunil just only, but the main Kishore Kumar is Dr. Sabnis. somebody who is always working from back, that is one of the most important things. Then coming to the many more. So the most important thing that we can't heal the world today, but we can begin with voice of the compassion, a heart of love and act of kindness, and with our big good intentions. The healing is always improvement, and always we do some positive things in somebody's life. How the Rotary Club of Bombay Seaface has rushed to help. So there are certain examples, a few happy stories. So this small child, 4 months old child, Naksh Dhingra, hailing from Haryana, residing in the rental home in Powai. The father is and mother is only working person who is not having that much financial support from his occupation. The child is suffering from coarctation of aorta, and the Rotary Club had funded the procedure, and now the child is gaining weight and improving without any symptoms. Then this is another patient, Jalak Singh. This case was having, this small child was having large ductus arteriosus with a heart failure, and she is coming from the village Patna, Bihar, and because they are coming from out of Maharashtra, most of the time they don't get any government schemes which are available in Maharashtra most of the time, and these pediatric age group patients, the conditions are so worse that we can't wait also for getting that particular paperwork to get rectified and take the support from the government. And at that time the Rotary Club helps us, and this particular procedure is done by the surgery department. They have ligated the PDA. Now the child is gaining weight and she is now improved a lot, and she is subsequently now she will go to the school. And the most important thing is that the PDA ligation. So the ligation of PDA is a total cure. So now she will be totally cured. So there will be normal longevity. So she will, the life expectancy will be like a normal life expectancy. So there will not be any reduction in life expectancy. So she will live till 100 years. Then this is another case of coarctoplasty, similar thing. The 2-month child belonging to the Nanded suffering from severe coarctation of aorta and failure, and because of the lacunae in the paper, they were not getting any support from government of Maharashtra, and at that time the patient was in failure. We approached you people on only telephone, on only WhatsApp message, and you people supported us, and now the child is improved a lot and they are all success. So then balloon pulmonary valvuloplasty, sometimes the pulmonary valves are constricted. This patient is coming from Vasai, is college student, and the most important thing is that the government scheme doesn't support with a full reimbursement of this particular procedures. They give only 20,000 rupees, and in 20,000 rupees we don't get any hardware to do the procedure, because, and if we want to do the procedure in a lower cost, then we have to reuse the thing, and we don't reuse the thing. We always use everything new for that particular patient, and then we throw it out. So we always stick to the protocols and guidelines, and because of that we sometimes need your help in doing certain interventions in this type of patients. Then this is also same patient, like a similar patient, like a balloon pulmonary valvuloplasty. She is Anita. She was residing of Karjat, and she was pregnant at that particular time, and ultimately after procedure she successfully delivered. Then another important procedure is balloon mitral valvuloplasty. So mitral valve is one of the complex valve. It is on left side, and the symptoms are like a breathlessness because of pulmonary congestion. And these particular patients with the mitral stenosis, they get significant deterioration in the symptoms in the pregnancy because of intravascular volume. And in pregnancy, we have to do this particular procedure preferably at the end of the second trimester to reduce the radiation-related problems in the fetus. And this particular procedure is very successfully done in our KEM Hospital, and we have taken the support from the Rotary. Then this is also a similar patient, balloon mitral valvuloplasty. She was also pregnant, and she was a Chandrakala Gupta. So sometimes you people support, but sometimes God doesn't help, and some tragic stories are also there. This patient was also supported by Rotary Club. We had done a balloon coarctoplasty, but subsequently because of septicemia and other comorbidities, she succumbed. Then this patient was supported by you people to do a very complex cardiac surgery, that is normal procedure for hypoplastic left heart syndrome. But subsequently, after normal procedure at day 10 of the life, she succumbed because of complexity of the disease process. So alone we can't do so little, so together we can do so much. So the most important thing is that we always need your blessings and your positive approach for our patients, and that much is needed from your side for me. That is it.
Dr. Sabnis, would you like to add something to this?
Yeah, all I can say is from taking over from where Sir left, any institute, especially a government institute which caters to really desperate people, and especially KEM caters to people from all parts of the country. Means even a person who lives in the outskirts of Delhi comes all the way to Bombay because they say it's much more easy, accessible and affordable. So any such great institute to do great work for the common man just needs a few dedicated people. So if I could count us as one of those dedicated people need two things. They need a very generous mentor who has faith in them, who teaches them and who gives them a free hand. And they need a friend such as a Rotary organization. It's literally been a kind of a dream donor, because whenever we need donations we have to really prepare long projects, wait, beg. But here it's like we just send an SMS to Mr. Bhalera or Poona madam, and the next day patient just comes with a check. It's like rubbing an Aladdin's lamp. So we are really grateful to you, and we hope to do much bigger. Thank you.
Meenaben, can I add something to that?
Yes, please.
First of all, thanks a lot, Ajay, because this is a global grant that we started in Nirmal's year, and we can make do something like about 45 to 50 pediatric surgery. And one of the students of the KEM, Dr. Ila Shah, she has contributed US $16,000
yes,
for this. Okay. So I'm so happy that we have these speakers, and we can now show to our members that how our global grant is doing the work for your patients. Thank you.
Rina has something to say.
So, the friends, whenever we are coming for the foundation money, the people are asking where our foundation money is going. This is the foundation, what the Rotary Foundation is helping us to doing this. So every $1 of our TRF is helping this. So the whomsoever is sitting over here, I request everyone, whenever we call somebody, please donate for the TRS, and so that we can do more and more global grant and we can help such kind of people.
I second.
Rina, this year I want our club to be EREY club. And which yes.
I can tell you this global grant, okay, the $10,000 were given by our club. 16,000 came from Rotary Club of Charlotte, which is Dr. Ilasha is a member. $4,000 have come through the members who contributed $500. So this is like what I'm saying, she's talking about TRF. And that's how we got a total project of about 36 or 37,000. 37,000.
So the TRF is giving us a very big chunk of the money to come in, and so that we can cater this and 40, 50 children, and we are getting the pleasure of saving the 40, 50 children's life.
Thank you, Rina, for the information. Can I request Dr. Snehal and Dr. Pankaj Parekh to continue with the question answer series? If members have any other questions, you please come forward. Otherwise, they are going to carry the question answer session.
Yeah. Good afternoon, friends. Wonderful presentation, Dr. Ajay, and well said, Dr. Girish. We realized one thing, that by Annapurna project we help hungry stomach. By this project we help hungry hearts. And this is very important because Rotary Club never realized that this will be so much life-saving, and a prompt help is so important. Any question, Doctor? I have been a student of Organised MD in 1976. So when I think a pediatrician, we know a lot of problems. We have one important question. Just to explain why I am asking this, there are two ways we do surgeries. We open the heart, what is open heart surgery, and we do a device closure, like he said, VSD, ASD, PDA, coag, pulmonary valve, all those things. We only put a catheter and do either a reconstruction there, close the defect, or something is tight and we open up the thing. It's called as a device management. So open heart surgery always has a lot of morbidity and mortality, in the sense you open the heart, you do a lot of structural repair, come out. So a lot of handling of the heart is done. It is a lot of complicated surgery and it takes long time for the patient to recover. The stay in the hospital is longer, the finances are big. Device closure, quick response to the tune, maybe in 48 to 72 hours. If the doctors feel stable, the patient can go home. And you don't see a single scar on the chest, the patient's heart is cured. The only question was, is there a major cost difference between a open heart conventional surgery, what says for example large VSD, and you compare moderates to mild, small size VSD to device closure? So is there a major, is it more expensive or not?
See, the device cost and surgery cost, they are equal, because surgery also needs all disposables, and these surgeries are on cardiopulmonary bypass. So we need a membrane oxygenator and filters and all those things. So the cost of disposables in the surgery and the cost of disposables in the device, they are really equal. But the most important thing is that the surgery also need additional cost of ICCU, then intensivists, ventilation, and those things are slightly higher. And hospital stay is more longer in surgery as compared to device.
I being an anesthetist, I have worked more with the open heart surgeries. Those era there was no conventional devices.
Yeah.
So those days we have done the closure of ASD, VSD, coarctation, everything open heart. And I think the mortality was much higher compared to now what you have it. So that's, because those was Dr. K. Dastur, Dr. Kalke's era.
I am from KEM, by the way, from long back 65 to 75. So I congratulate you both of you, because the way you have been doing work, I know how difficult it is to work in KEM and to get the money and to get the patients, a lot of thoughts, but it has always produced brilliant doctors. And not that because I am KEM on time, but so many, some very neurologists you take, the great interventional cardiologist is there, Dr. Kelly, as he said, is not them. So they really are doing great work. For us members, you may not understand what is going on. Are born with these defects, you must be knowing. Heart chamber is one division of left and right heart. So there are 4 chambers are there. So you must have experienced, sorry I intimidate because of emergency heart. So there is a hole in between, and this hole has to be corrected in right time. So if you correct it in the right time, then the future, when they become adult, it is good. I was going to ask 2 questions. One, so they have got a congenital heart problem. That's why when the Pankaj Parekh is there, they don't come to me, I'm an adult physician. So they find it and then they refer to the interventional cardiologist, etc. Basically, both of you only pediatric cardiology work, or
No.
also adult?
We do all
kinds of those. Now in adults also, a lot of problems are there. Some of these pediatric people or small ASDs and VSDs are there, their own defect, atrial septal defect. They don't do anything at that time. And we have people from the class and education wise, they become even go to 20, 30 years also. And then they start getting symptoms. So you also handle the adult defect. It is called adult congenital heart disease.
Yes, adult congenital.
We've been doing.
Yes.
Then another interesting for all of us, that valves have been always a problem. In our country, particularly because of rheumatic fever and otherwise also some valves will defect on the congenital. So this aortic valve is very important when the blood goes out from the heart. And I am sure one of or two of us, some relative must have asked a question or informed that I am undergoing the valve surgery, aortic valve replacement thing. There also, there is a big chain. We call it transaortic aortic valve replacement. TAVI and TAVI. We have been there also. So we all must remember this.
So we are doing some TAVIs free of cost to the patient.
So we have to really encourage, because it is again a very costly surgery. The cost of the valve is quite a lot, and if I don't mistake it, in private it goes to in the Lands Hospital 17 to 20 lakhs minimum. And if you use the lower valve, lower cost valve, Indian valve, it goes to I think 10 or 30. It goes time and again, so many times that we are stuck because I don't have that much money. I'm a middle class guy to tell to get out 13 lakhs and not sure, or 15 lakhs. So I think all these people who are doing work, we have to really encourage them, appreciate them, that they are doing really good work. And you do valve for the aortic valve replacement, how do you manage for the valve? Because the valve has to be purchased, so how do you manage that part?
See, I am one of the SIG committee members, so one of my biggest achievement is that I was responsible for reducing the price of the stent. So I was the only person from the Western India in that committee.
Okay.
So we brought down the cost to the 30,000 rupees. Now it is just 31,000.
Yeah, that's 10. What about this valve?
So because of that committee things, most of the valves which are coming in India for the marketing, we get a phase 4 trial, and out of that phase 4 trial, the KEM is one center, so we get a free one. So that is.
So this also you all must keep in mind.
And if the patient doesn't fulfill the criteria for phase 4, and in spite of that, if patient has to undergo the procedure, then we get a subsidized cost with the Indian valves also. And in some patients, we take a free year.
So all of us can remember that valves also in adult people, this becomes an adult word, has to be replaced or repaired. Mitral valve clipping or repairing, that also, everything is being done.
Mitral clip, that is a clipping, yes, we have to start that program. We are going to start within the next 6 months. Because of COVID, it is taking some time.
Yeah. So basically, the children who are born, because I think one other lady was here, used to come from another club, where they do a lot of work for correcting this ASDs and PhDs and whatever complicated work, basically congenital heart, and which has to be repaired, otherwise the future is bad. And in adults, valves are wrong, aortic valve and the mitral valve commonly hit, and they are handled by these people very well. I think this is he must be doing, she's a Rotary, and she is doing mainly pediatric. Rotary part, I know, like you understand, you all must be doing better. She's been working for all congenital heart people. So the thing is that we congratulate you and we encourage you, and our Rotary Club is always there for you people. And any other question, comment I have from you?
There's a small story why I want to tell you all this, guys. This is a true story. 35 years back, more than 35 years back, a baby was born in my family. This was born at Elizabeth nursing home. After the birth, the baby was very breathless. I had just graduated in a pediatrics and only 1 year in practice. So I'll tell you exact year is 1979. And this baby, we could find out a murmur, and the child was in cardiac failure with cyanosis. Cyanosis, the baby was blue and breathing very fast, his heart was failing. Just born in my family, this is happening. There was no one to do echocardiography except one Dr. Munshi at Jaslo, who will do M-mode. Sushil Munshi, M-mode, and not even 3-dimensional number, a very primary way of doing echocardiography. What he said, Dr. Parekh, I can find out if there is some complex heart. And this complex heart cannot be managed in India. It was true. In 1979, nobody was operating. Incidentally, Dr. Subramaniam, then a pediatric cardiac surgeon, one of the eminent pediatric cardiac surgeon, and graduated from India, had come down to conference. So Dr. Munshi said, if he comes, if he has time, he will see that patient. So he came and showed that patient, I don't want to keep this child here. This child should straight fly to USA. And there's one incident I know that in emergency US visas were given to family on Sunday. At the recommendation of Dr. Subramanian, on Sunday the whole passport was stamped with a visa. The child he had to go to Buffalo. He was operating at Buffalo. So Bombay, New York, Buffalo. So in Bombay, they stayed in the flight, the patient became serious. Small baby, 5-7 days old baby became serious. Incidentally, Dr. Subramanian also was traveling in the same flight. See, look at what you said then. It's like when the God wants to help you, it will help you with all the four hands. And sometimes when you are bad luck, your desired best of the doctors are out of Bombay when you are sick. It does happen. So you must bless the God. Dr. Subramanian was there and he said this child cannot reach Buffalo. So there were a few hours left, so he called up through the flight to his institute. They got an intensive care ambulance. He didn't have that concept that time. On the Newark airport. With two intensivists and a cardiologist in the ambulance. They stabilized the patient on the Newark airport. With the same ambulance, they didn't even take father and mother. Dr. Subramanian went in the ambulance from New York to Buffalo, operated the child, and the son is a proud father of a daughter, is 38 years old. So you can imagine how much the cardiac surgery has changed, from where to where it has gone. Maybe in some time the open heart surgery will be completely obsolete. This guy
No, I would not agree.
No. What I mean,
It will not be.
of course, what I mean is, there is so much of the great work.
See, I have to. There are some different views about this particular thing. See, the surgery is also science, and it is a very skillful science. There is no alternative to surgery. Surgery will always remain. When we are working, we are having all limitations. If the surgeon is there, and if the surgeon and cardiologist are there, then it is a complete thing. Without surgery, we can't do anything.
No, I agree with you, because I practically meet 5 days a week with Dr. Prakash, who operates at Reliance. So we are very close, and we talk in intensive care. I would like to invite questions from the audience, where your experience in the family or anybody, or where you have to, I understand it's very difficult for you to understand what is VSD, SD, PDA, and 111. So all those things are very difficult to understand. But don't hesitate to ask. However, it doesn't look appropriate. Ask, because there are so many things which is not known to people. When they have to do a procedure or a surgery, the counseling is such an important part to the parents. For them, for these champions, it may be a very simple procedure, but for parents, it is the child. It is the child's heart in the procedure. The cost comes in a picture, but the maximum anxiety comes about what will happen. Will the child survive? If he survives, will he be normal throughout the life? So any such questions you want to ask, please.
Doctor,
Yeah.
Last year I was on the International Pediatric Heart Surgery. I was the admin chair from the district. We used to get the patients from the Africa, most of the part, Kenya, Tanzania, then Uganda and everywhere. They are saying they have this problem genetically. How can it be the heart disease can be a genetic?
And see, there are certain diseases which are common in certain continents. In Africa, because of underdevelopment and because of slightly increase in the more prevalence of rheumatic heart disease, now in India it is significantly reduced. The rheumatic heart disease in India, which was there 20 years back, and now they are totally different. 20 years back, we used to do at least 2 PM balloon mitral valvuloplasty every day. Now we are doing one alternate day, something like that. But in Africa, the same thing is still persistent, and because of that, they are having more prevalence of rheumatic heart disease. Another important thing is that they are having only diagnostic facilities. So now only diagnostic facilities are pouring in those countries, and they are getting some trainings in diagnostic things like complex color doctor examinations in congenital heart disease and other things, and because of that new things are now more picked up, and because of that they might be getting a more number of patients, but there are nobody who can do the procedures there, and because of that we are getting the patient from there. Within next 2-3 months I am going to there in Africa for proctoring the thing. Previously I used to proctor the procedures in Northern Africa, then in Yemen, in Mongolia, in Uzbekistan and other places.
And another question, congenital. Then congenital means during the development of the child's heart or the intrauterine, there is some defect. So whatever that becomes a congenital. The hole in the heart will remain which is
Somebody born with the 6 finger.
6 fingers.
Somebody
Right.
born with the
Is there,
defect.
now the most of the pregnancy they are taking, they are doing the sonography. Can't they find out?
No, they
No,
don't.
all everything
See,
can
now with the invention of the new machines, here we can detect the cardiac anomalies at an early stage when they come in the pregnancy stage. Whereas in those countries, they don't have such expertise over there.
And
So-
the birth defect basically.
So these are basically the birth defects which are diagnosed either in pregnancy or post-pregnancy.
No,
They are
because
very
in the one
complicated.
parent, she had the one Uganda patient had come to us. There were 6 children. Out of 6, the 4 had having the same problem.
Yeah, so that goes and runs into the family.
She is talking about, I think, genetic
Genetic.
Yes.
There
how
will be
which one
official.
is going to be transmitted.
Yeah, you wanted to ask something.
We were just talking about the sonography part.
Yeah.
Recently
Is it
only,
video notice?
we had a case and we found that in the Phallus tetralogy in the baby, and the parents were explained everything and they understood everything, and then they decided, we want to continue with this pregnancy. Whatever comes later on after the birth, we are ready for it and we will go ahead with it. Only thing, we have the advantage that we know in advance what is going to come. And one more thing I just wanted to ask them. I think Christian Bernard, he did the first heart transplant way back in, I think, 69?
Yes, 69.
1969. And after that, there was such a long gap.
20 years, I think 15-20 years. KEM
KEM,
was
Dr.
the
Bharera was
first.
there.
First in 16.
Dr. Bharera, he was in
KEM was the
St.
first.
Dr. P.K. Sen had
P.K. Sen.
heart transplant in India.
But the patient unfortunately didn't survive, I think.
Ah,
And then there was a lot of setback and people were scared to do the heart
Yeah,
transplant.
but such a long gap of so many
See,
years.
this all is, now the transplant is only because of, possible only because of the immunosuppression protocols. So because of immunosuppression protocols, the heart transplant is now picked up.
Otherwise,
Otherwise, rejection rate is very high.
Very good. Yeah, Dr. Ajay said one here.
I'm a family physician. Promise of your excellent work. Only we at this level we don't know much what we are doing, because in my community, in my family, the physician, they don't know what is going on. They should project us, so they should know it, what is available, what are doing. This is what I want to ask you. And secondly, BMC was such a huge amount, like, you look at like, why not to invest much in the KM to be a facility for them?
that is very unanswerable question from years and years.
Yeah.
No, I was actually going to the same thing with folded hands. I think you all are doing a fantastic job. I am sure most of us, what we have seen through, must not even be knowing what exactly are these things and the procedures and the things that are happening over there. When we come across anything related to our heart, we jump to branded hospitals, high-profile doctors when we don't approach. I think they are doing a fantastic job, sir. I think that awareness needs to be created. Wish you all the best for this.
Now, one of the most important things which we do in KEM Hospital or all other BMC hospitals is we are giving maximum support to the patients with the acute myocardial infarction. So if the heart attack patient comes in casualty only, the ECGs are picked up, so all ECGs are flashed to everybody. So now it is in the group. So I will also see, he will also see, everybody will see, and if required, we can do primary angioplasty, and if the patient is having ration card with him, everything is free of cost. And we are
doing
using,
angioplasties also, basically, everything.
we are doing maximum, and you name the complex angioplasty, and we are doing bifurcations, left main, triple vessel, rotablator, everything we are doing. So the angioplasty is the major thing which is done in the department. So we are doing around 150 angioplasties in a month.
Oh, wow.
That's it.
You know, I got
So
from your
one of the most dreaded complications of the heart attack is a ventricular septal rupture. So we are doing the device closure of the ventricular septal ruptures in acute myocardial infarction. All complications.
But this awareness needs to be.
Whether ASD and VSD, there is any size dependent when you do the interventionary correction, or bigger ASDs or VSD, you have to do the open heart surgery.
See, for ASD, the most important thing is that if there is a primum ASD, the surgery is the thing. If there is a sinus stenosis ASD, some people are doing intervention in sinus stenosis ASD, but still we are preferably sending those patients to the surgery if there is associated other anomalies like a PAPVC. The most important ASD which is amenable to the device closure is the second term ASD, but without our important investigation like a transesophageal echocardiography, we can't complete that procedure of ASD device closure. For VSD, the most important is the size and site. If the size and sites are suitable, then we do it a device closure.
And it's from your doctor, there's a one suggestion we can do. Since the Rotary Club is spending a lot of money in helping in curing these defective hearts, why not we put some budget to make a publicity of this, what they are doing, and so it can be beneficial to so many people. I think some of the good work, what they are doing in the prices and what economically, how well it can be done, and how Rotary Club can help. If you can give in some of the publications outside in the newspaper or somewhere, I'm very sure many people will come forward, not only to help, but also to seek the help.
Well, maybe I'm going to do this at the Hindu Gymkhana level. At Hindu Gymkhana level, I'm going to do this. We are having the flag hoisting ceremonies on 15th of August. I think we are going to take this as a campaign to create awareness among people. I think it's a fantastic thing.
The word of mouth, people reading in the newspaper.
With our social media, we can just.
To be fair to the Bombay Municipal Corporation, they do support us tremendously. They provide us with the best of equipment. We have better cath labs than many of the so-called branded hospitals. Each cath lab costs 10 crores. The eco machine costs 1.5 crores. So these are things which are not present in many. So, but the numbers are so overwhelming, and they keep coming and they keep coming and they just don't stop. So the peak crowd on a Monday morning in a private hospital will be less than what you will see on a Sunday morning in KEM. So we do.
saw the photograph which Dr. Palera was.
That was just yesterday, so I had to ask security to let me through that crowd and get to my chair.
Classmate 1 year here and there with Manke and Bhattacharya. And I remember that night 3 o'clock was the dinner, and it was a hell of the work what was going on there. Korulkar was there, nothing else.
Municipal and government hospitals are overcrowded. People from all over the state and maybe all over the country come to these places because the economics plays such important. And imagine, we are talking about 17 lakhs. We went to Adivasi camp. If you remember, there was a one child where we detected murmur. Rotary Club camp, we detected murmur. And this guy, when I told him that his heart mein chhed hai, so without even asking, he became white, completely pale, and sit down with the child in the chair. He could not talk. Guys, a very idea of a heart surgery. The people who comes 10 kilometers walking barefoot to the pediatric free camp of Rotary Club, where is the question of spending few hundred rupees? There is day to day, they earn and they eat, they earn and they eat. The day they don't earn, they can't eat. Now such people, numbers are so big that you require few Ambanis to do all of them to satisfy all of them. The numbers are very huge, very huge numbers.
One second, Dr. Sabnis, just I wanted to know how much the KEM funds are giving the money for such kind of procedure.
We have started doing patients under the Ayushman Bharat scheme, and from directly the PM Relief Fund, it's limited so far.
So far,
Ayushman is from-
because how much is around 70
It's just we have a dedicated medical social worker department to approach as a CM relief, PM relief. But most of the patients who we approach you for have no idea on them at all.
The question is, if we approach to the CM fund or PM fund, so these offices are very efficient, they respond very nicely. But the most important thing is that in the emergency, they are of no use. Because if there is some elective surgery is planned, after 3 months or after 4 months, then we give the prescription, the surgeon follows, social worker follows, they get the money, they get operated. But for the emergency like heart failure because of coaptation or because of large duct or because of large UPSD or because of severe pulmonary stenosis, when the child is too sick, it is very difficult to get that support immediately, and in that case we need your help.
But do they give the full money for the this thing? Because I am overthinking this pediatric heart surgery.
No, you see-
And you get the patients lot.
No, see, as far as the Ayushman Bharat Yojana, there are certain packages. So, if we are in that particular Yojana, you get that package money. But if you are approaching the PM relief fund, so we have to send a full estimate, and sometimes they give 50,000, sometimes they give 1 lakh rupees, and
They
then
don't
we
do surgery for.
no, they don't.
May I request Ms. Eram to say the vote of thanks?
And she wants.
And you have a
She wants to
question
say.
also, so you can just ask the question.
Okay, what I wanted to say is that Rashtriya Bal Swasthya Karyakram, according to that, if you see the policy, it is there that every child born with a congenital defect is going to be treated free of cost by the government of India. It is there on the website. But somehow, this policy is not being worked out on. So that's what we are trying to do. Like, I don't know, Mr. Dr. Ajay Mahajan, but I have an MOU with KEM Hospital, with the leading investigator of this MOU is Dr. Anita Balakrishnan. You know, she, and we have an MOU with Nair Hospital. The head is Dr. Suki Rathi in Nair and Dr. Swati Manekar in Sai Hospital. So we are launching a novel technology in government hospitals for detection of congenital heart disease.
Both are
We are co-investigators.
Oh my God! So you have signed the MOU with me?
Yes.
Okay. So I'm
That's
from
really going to be quite helpful to the
Yeah, so that's what we're doing. So the thing is that in lives, so because of that we approached Rashtriya Bal Swasthya Karyakram that you've got to get organized right now, because if we get a tsunami of patients, because we are working there in only government hospitals, and then we will be launching hub and spoke models depending on the success of this pilot project, in which the spoke hospitals will be in the PHC centers. Already spoken to the Ministry of Rural Development. So the spoke hospitals will be in the PHC centers, and the hub hospitals will be the hospitals that have the capacity to carry out this surgery. Okay? So in that also, that this is the low-hanging fruit. We can only do this right now. But our next step is that we want to create capacity in government hospitals to carry out this surgery. This is the capacity of these private hospitals, which charge exorbitant. For example, as you said, certain things are when you are in an emergency situation, you cannot wait for approval of a fund. So one baby was dying, he had become blue, and the tehsil was closed. So his father could not get a certificate or income certificate. So nobody was ready to pay because he did not have an income certificate. So on my bond, I gave a bond in the hospital that I will pay. Because I cannot it was like become a moral duty, like either you give a bond and arrange for the money in the next 1 week or let the baby die. So I gave a bond. And then after the surgery was done, they did not accept the testing certificate. They said, no, now we cannot accept it. So that was one case. Second case was we came only from KEM Hospital. It was a neonate. And they said that we have to keep the baby for 3 days and then we will decide whether we will do the surgery or not. So then we had to be kept in the NICU for 3 days. And they said the cost of the NICU would be 1,85,000. I was like, what? Who's going to give that? Which Rotary is going to give for an NICU 3 days? Then they reduced. They came down to 56,000. Okay. Then I said, fine. I will agree with this much. I'll ask some of my friends to pay for it. And Then after 3 days it was figured that okay, the baby doesn't need surgery, she can come back after 3 months. So these are, these are big amounts of money, large chunks of money. We are just giving away. Because I believe somewhere there is a little bit of disorganization in the sector between the government and the private sector, which needs to get organized. So I know it's a high-ranking, but when we are giving crores of rupees on individual surgical funding, instead, why don't we, give these crores of rupees and capacity build a government hospital to start doing 3 surgeries? Yes, I do understand the high vote of thanks to Dr. Sabnis and Dr. Mahajan, and there is this ex-commissioner of police, Mr. K.L. Prasad, who used to say that when you want to see God, I don't see him in high philosophies, I see the great work that great people do. And then I think that if the creature is like that, how great would be his creator? So I would like to give that that compliment to Dr. Mahajan and Dr. Sabnis that this is what